So I just have a couple of background slides to take you through. First of all, some of you may be asking the question, what is REDS technology? REDS technology is an imaging technology. It's based on military see-through-the-wall technology. So here is what it does or what it measures. It measures lung water. And again, unlike other technologies that have looked at lung water, it gives an absolute measurement. And we know from prior studies that the normal lung is comprised of about 20 to 35% fluid content. And so we can measure in absolute terms how wet or how dry the lung is. And of course, in our heart failure patients, we want it to be normally dry within that normal range of 20 to 35% ideally. The REDS technology is FDA cleared and CE marked, so it is available both in the United States and in the European Union. So there really are 4 layers of clinical data or clinical evidence that supports the use of REDS technology. There is the basic data that looks at the accuracy of REDS, the REDS CT study, which validated REDS technology against the gold standard for determining fluid content in a tissue, and that is computed tomography. There is a clinical outcome study, the REDS HF trial. Both of these are published. Presented in pending publication, there is the REDS pulmonary capillary wedge pressure study, a hemodynamic comparison of REDS technology to pulmonary capillary wedge pressure. And then finally, and quite frankly, perhaps most importantly, is the real life or real world utilization of REDS technology. And we're going to share some of that information with you today. But let me just very quickly show you the first 3 levels of this pyramid. First of all, the accuracy of the REDS technology has been shown here compared to computed tomography to CT scanning for determination of lung fluid content, using phantoms, using preclinical animal studies, and then in humans and clinical studies. This information published in the International Journal of Cardiology last year, demonstrating a very high correlation between REDS assessed lung fluid content and that determined by CT. The clinical outcome trial that I mentioned earlier has also been published in the International Journal of Cardiology earlier this year. This was a pilot observational study comparing patients to themselves pre-REDS, during REDS, and post-REDS. And you can see that during the period in which the patients were actively managed using REDS technology, there was an 87% reduction in heart failure hospitalizations. And then that advantage was completely lost when REDS-driven patient management, REDS-guided patient management was stopped. And finally, the hemodynamic, there's a typo on the slide, the hemodynamic research, this from near Uriel in Chicago, demonstrates a very high correlation between REDS and pulmonary capillary wedge pressure. The sensitivity is about 91%, specificity 77%. The negative predictive value for a wedge pressure of greater than or equal to 18, so essentially hemodynamic congestion, is 95%. This is really terrific data. And you can see that it very nicely discriminates left heart failure and biventricular failure from no heart failure or right ventricular failure. So with that, we're going to move into the 4th layer of evidence here, and that is real-life usage results. And there are multiple uses across the continuum of care. You'll hear from the experts here today that there is utility in using REDS in really each of these settings, all of these settings, from the home into the nursing home, in the emergency department, in the hospital, and in the post-discharge setting. So with that, we're going to move on to our experts here, and we're going to start with Sanjay Dhanamani from Geisinger, who will talk a bit about his experience.
Thank you, Bill, and good morning to you all. It's an honor and pleasure to be able to share our early experience using this technology. We felt very confident that we could take a technological application and put it into clinical practice with a strong implementation plan, and that's what I'm going to be sharing with you and some of our early data. So I don't know if this slide shows very well, but we really took our broad heart failure patient population that had utilization either in the emergency department or an inpatient admission, and we divided them into crisis level patients that needed some form of active daily management, into high-risk patients that had a history of either high cost or high utilization, and into low-risk patients that may have had a one-time aberration of a hospitalization or an emergency department visit and had heart failure that was active, but were really presumed low risk by virtue of their symptoms and their exercise tolerance. We excluded patients who had some form of either contraindication to having the device placed, such as a right-sided implant, or a high BMI, or aberration in BMI or height, as well as participation in the SMILE study that was occurring concurrently. So our process flow really hinged upon the clinical decision to get patients enrolled into the REDS vests, and that was decided by a specialty RN case manager who's focused on heart failure, but really out there in the community. We used a low-cost model of a high school graduate level non-licensed employees. These were community health assistants, and they were the ones going house to house to be able to place the vest on the patient. There was a learning curve. They had to do 10 supervised applications and then go out into the community. And they had support from the company as well to be able to perform these tasks as they learned to become experts on applying these devices. They would then circle the results back to the heart failure nurse navigator, especially if there was an aberration that was high or low. And otherwise, for the vast majority of them, they would just communicate the results to the community case managers. We followed the highs and lows from what we were given from the company, but through our own learning, really felt that between 30 and 35 was optimal, and that 36 to 41 was sort of trending towards the high, although a lot of our heart failure patients, especially with advanced heart failure, sort of trended into that bucket, and that patients who were under 25 were quite symptomatic in terms of being volume depleted. And what we found when we just looked at the first 30 or first 28 patients that we had being actively monitored was quite striking. For the first, we had almost half of those patients hospitalized within the prior 30 days. The second is applying this technology was actually relatively easy to do, and the community health assistants were very energized and charged to being able to participate in healthcare, sort of direct hands-on with the patients, which was amazing to see. We've had some amazing results in that post-vest application. We've had a decrease by 75% with only 4 patients requiring hospital-based therapies, and the vast majority of patients being treated successfully at home. We also have a mobile health paramedic program that goes out and provides intravenous diuretic therapy in the homes, and we have some other home-based therapies that have probably helped make things easier for the patients at home to receive treatments. So I'm going to just quickly share a couple of cases. This gentleman has multiple comorbidities, advanced age. A long time ago was diagnosed as having non-obstructive coronary artery disease, but with the ensuing CKD, never had any reassessment by cardiac catheterization. was hospitalized multiple times, 6 hospitalizations prior to May 11th when he got the vest. And since May 11th, he's had 0 ED or hospitalizations for heart failure decompensation or for any cause. Now, what's interesting is in this past week, the patient has started to terminally decline, but not due to fluid overload, but just really due to pump failure. And so the patient is actually now on hospice. And what's interesting is that the family did not want the Reds taken off even in hospice. So the second patient has been a really non-compliant patient, in and out of the hospital, continue to have high readings, and really needed to be shown their own graph for them to start, getting into the yellow zone and sort of improving and turning things around. So I think this could be a powerful tool in compliance. The third case, we kind of averted a disaster. The patient was scheduled as on somewhat of an urgent basis to having a peripheral angiogram and a toe amputation. And we actually met with them in the pre-op clinic the day of the surgery and had the surgery moved to like 48 hours later, placed the patient in heart failure observation and diuresed the patient before they went in for their operation. That patient has really improved over time and has relatively been devoid of any heart failure symptoms since that episode. So I'm going to hand this over to Dr. Ben Simone, who's going to share the experience at Cone.
Thanks, Sanjay. You got it? Can you hear me? Good. Thanks, Sanjay. Good morning, everybody. Thanks for having us. Tell you a little bit about our program. Moses Cone Hospital, or Cone Health, is a 7-hospital system in central North Carolina. We are a VAD center, we're a community VAD center. And one of the things that we've really focused on over the past year or two is how do we help the hospitals around us improve their metrics that don't have heart failure programs? How do we help them treat their patients better, meet their metrics without actually seeing all their patients at our hospital? And the other thing is ask, how do we also support providers in our hospital who may not be heart failure experts but want to do a better job triaging and treating these patients? We're a busy heart failure center. We have 125 discharges a month from our hospital. We have 5,000 visits in our clinic. We have 2 physicians and 2 mid-levels. So we're a very busy center, and we try to reach out, but we're like everybody else, we're strapped for resources. So we're looking for technology to sort of help us solve these problems but provide care. We have an extensive experience with the vest now. We've been working with it well over a year in multiple situations. And I'll try to go through it fairly quickly. But this is our center. We're Moses Cone here. Cone Health is our flagship hospital. It's a 500-bed hospital. We have one of our hospitals in our system is Alamance Health, which is about 30 miles down the road from us. We have a very large ACO. We have 40,000 patients in our next-gen ACO, and we're responsible for these patients when they get care at other places, we're responsible for picking up that tab as well. So we try to keep them in our network as much as possible. We partner with several nursing homes, and we also have a hospital that's 30 miles south to us called Randolph Health. That's not one of our sister hospitals, but very engaged. They're part of our ACO, and although they have a cardiology program, they really haven't had a heart failure program. So we're looking for ways, how can we reach out, how can we affect patient care without having to see more and more patients? So I'll give you 2 examples. We've done work in all these domains, but they told me I only have 7 minutes, so last talk was 30 minutes. So I'll give you just 2 quick examples of what we've done. So the first thing was a discharge study that was done at our center. As I said, we have 125 discharges per month for heart failure at our center. The heart failure program sees about 25 patients to 30 patients a month. So there's about 100 patients a month that we are not touching in our hospital center. And our thought was much like the ADHERE registry, that most of these patients are probably being discharged too early. They're not fully congested, and maybe that's a factor in readmission. So what we did is when patients were admitted to the hospital, we enrolled them into our study. And then at the time, they either got a control arm or a treatment arm. And at the time of discharge, when the hospitalist or the primary cardiologist said, this patient is ready to go home, one of our research nurses or pharmacists would go to the bedside and measure the patient with a vest. Now, as Sanjay said, 25 to 35 is sort of the dry range. Like Sanjay, we said many of these heart failure patients go a little higher. So we set the cutoff at 39. If you're 39 or higher, we felt that might be a problem. So in the treatment arm, if your primary care your provider said you're ready to go home, and your vest reading said 39 or greater, you got a visit from the heart failure team prior to discharge. If you were in the control group, you got measured, but your readings went to the cloud, and we were unable to act on them. So as you see, we said wet in the treatment arm, had a heart failure visit prior to discharge with heart failure clinic follow-up. The people over here in the control arm just was treatment as usual care. And obviously, if you were dry, we let you go home. So what you can see is we sort of, the first interesting point of data we came up with that is that, in fact, yes, 33% of patients are being discharged from the hospital, not fully decongested, with a reading of 39 or higher. And this is not 35 or 36. This is 39, 40. These are numbers. We even got patients up into the 50s. These are patients who have significant congestion and who are being discharged from the hospital. And you can see, if you go back to this, there's a slide that's not here. The average weight loss in this population was about 5 or 6 pounds. The length of stay increased about 2 days. We had several patients that diuresed about 15 pounds of fluid. And there was no incidence of worsening renal function. So we were able to more fully diurese these patients. We were better able to titrate their diuretic regimen. And the final thing was we were actually able to identify these patients as a high-risk group. Some physician looked at them and said they're ready to go home, and their fluid was still elevated. So these are the patients. Instead of enrolling everyone in the heart failure clinic, these are the patients we moved into the heart failure clinic. And what you'll see that looking at the wet group in the treatment arm versus the wet group in the control arm. So there's about 18 patients in each arm. And you can see in the patients in the control arm, we had 4 readmissions in 90 days in the people who were treated with usual care versus 1 readmission in 90 days. If you look at 30 days, there were no readmissions in this group in 30 days. So significant reduction in readmissions over this time period looking at the discharge study. And here's the data we were talking about. So I think we have a way to support our hospitalists in this situation. We're no longer using it. The study's now wrapped up, and the hospitalists are still calling and say, hey, can you come take a look at this patient before they go home? Our second use case scenario is with this hospital about 30 miles south of us that's been a partner hospital, has a couple of cardiologists down there who are very busy, but do not spend a lot of time in a heart failure program. That said, they have a very, very engaged employed home health program. There's 3 home health nurses who are very engaged in the heart failure program. And they were looking for ways to go out and triage this patient population. And they had been doing it, although with good intentions, fairly unsuccessfully. Every year over year with readmission rates in the 25% range, very high readmission penalties. So our goal was to get together with them and give them a tool that was actionable. So when they went out to see a patient, they could look at the patient and say, oh, this patient, I think they look wet. Let's measure it. So we bought them a vest, we gave them a vest, and we, in conjunction with our heart failure pharmacist, we created a diuretic protocol. If the number's this, do this. And so we enrolled the patients, and what they would do after discharge, they'd go out once a week, and then as needed, if the patient calls, I'm not feeling well today, they would go into the house and measure their fluid. So we now have over 50 patients. This was 44 patients. And you can see in this group of this patient population, over this 3-month period, the initial period, we had a 2.3% readmission rate in this group that we were following. We had 1 readmission for a drug overdose, no readmissions for heart failure. There was a 13 times, and now we're over 15 times, where the diuretic protocol was actually implemented. And realize there was, aside from a few texts back and forth with me, there was no physician involvement in this program. This was all run by 3 nurses in a home health situation and a protocol. So there were no admissions for worsening renal failure. One patient came off of hospice. This was a very well done program. If you look at the hospital's overall readmission rate, the hospital's overall readmission rate went from 23% in 2016 to 14% in 2017. They became only one of a dozen hospitals in North Carolina to avoid readmission penalty this year, and mostly because of this program. There are other things that were implemented to help this program, support it, but this was the driving force in the program. So that's it. Do you want to have it, Charles? You want to have a quick question? Or we'll get it after. Want to just get it afterwards? I'm going to turn it over to Sean.
Thank you, Dan. Is this on? Okay, great. What I'm going to talk about today is the use of REDS technology in our rapid follow-up unit. So you've seen this slide now several times. I'm going to focus on this arm, which is the link between home to follow-up in the outpatient heart failure clinic. For the past 2.5 years, we've run what we've termed as a rapid follow-up clinic. This is a nurse practitioner-run clinic with indirect physician oversight, which has as a goal of seeing everyone who's discharged from our hospital with a primary heart failure diagnosis within 7 days of that discharge. So we thought that this would be a great opportunity to see these patients who are coming early after their hospitalization. We all know that several of those patients leave the hospital congested. There are other patients who don't look congested, but we know still are congested or rapidly become congested. We thought this would be a great opportunity to use REDS technology to identify those patients who have congestion so we can act upon them early so that we can prevent a 30-day rehospitalization. So starting in July of this year, we've been using the technology. We came up with some general guidelines for its use. Our nurse practitioner will do a standard assessment, vital signs, physical examination, electrocardiogram, and of course labs to make sure that renal function is okay. And then we'll put on the REDS vest and do a reading. We will look at that reading, and based upon that, we have a treatment algorithm. If the REDS reading is less than 20%, we reduce diuretics. If it's between 20 and 35%, we continue the current diuretic regimen, but very importantly, we look for opportunities to increase neurohormonal blockers, ACE inhibitors, beta blockers, sacubitril valsartan, or spironolactone. If it's over 35%, then we will increase diuretics. And then lastly, very importantly, we've created a special note section within our electronic medical record to capture all of these actions so we can go back and analyze our experience. So what do we do for those individuals who need an increase in diuretics? Very simply, we double the dosage for 3 days. Sometimes we do it a little bit longer if our nurse practitioner thinks that that's the right thing to do. And then we rapidly reassess those patients within a week or two. We assess their REDS reading, and if they've gone back to baseline, then we resume their previous diuretic dose. If they're still above baseline, then we will increase the diuretics and see them again, or we may add metolazone to increase diuresis. Very importantly, we closely follow these individuals. We want to make sure that their electrolytes are okay. We want to make sure that their renal function is okay. I can share with you some preliminary observations. Again, it's only been 2.5 months or so that we've been using this point of care testing. We've been able to screen 28 patients who were seen in rapid follow-up who had the vest applied. We are going to assess their volume status and correlate their symptoms to reduce these readmissions. We look at heart failure-related readmissions and in this small group of 28 patients, compared to a historical average 30-day readmission rate for heart failure hospitalization, we reduced it from 12% to 3.5%. That represents a 70% reduction in readmission for decompensated heart failure. Importantly, 16 of those 28 patients had medications adjusted, either their neurohormonal antagonists or their diuretics. Some of the things that we've also learned is that patients really like this vest. They like getting that number. They like getting that instant feedback to know where they are in their spectrum of heart failure. This is just one example of a patient who we saw a couple months ago. He's a 45-year-old man with dilated cardiomyopathy, happens to have an LV thrombus, chronic kidney disease, and a low ejection fraction. He'd been hospitalized 6 times in the preceding year, and when we saw him in that first point early after his discharge from hospital, we found out he was still congested. In fact, he was close to 42 or 45% lung water. So appropriately, we doubled his diuretics to from 40 milligrams twice a day up to 80 milligrams twice a day, had him come back in a week. We saw that we made a little bit of progress, but he was still congested. So we doubled the diuretics again to 160 milligrams twice a day. And I will let you know how it turns out. He's coming back next week. He's going to have a follow-up visit. I'm hoping that our intervention in doubling the diuretics will improve his lung water content. So some early observations. What I've heard from our nurse practitioners is that the vest is very easy to deploy. It takes about 3 minutes to properly size and fit one of our patients and to do a reading. The patients, as I said, like this immediate feedback. And most importantly, it's not disruptive to our workflow. We have noticed that we haven't been able to capture everyone. There are some reasons why we're not able to use the REDS technology. Some of our patients are too large to get a reliable reading, and a few have actually been too cachectic or too small. But more often it's that they're too obese. We've had some patients who have had a Hickman catheter or a perm cath where we didn't feel comfortable putting the vest over that catheter. And some of our patients had a life vest, and one or two of them just didn't feel comfortable taking the vest off even for 3 minutes. There have been a few patients who didn't want to do it and they refused, and we were respectful of that. And then we had some who were already participating in the trial, so we did not include them in our analysis. So just to wrap up, we have a few next steps that we want to look at as we continue to use this technology. We want to compare the use of patients who are managed with the RED system to a larger cohort. We want to look at readmission rates at 30 days and also, importantly, at 180 days. And then lastly, we want to drill down on those medication changes that we made in those 16 patients. Not only what was the change, was it mostly diuretics or was it neurohormonal antagonist use, but what was the directionality? Or how often are we going up? How often are we going down? And I look forward to sharing that with you probably in another year or so. So with that, I'll turn things back to Dr. Abraham.
So fantastic, guys. Thank you so much for your presentations. You know, what I find truly remarkable about your experiences is the concordance. Multiple sites, multiple use case scenarios, and reproducibly we're seeing about a 70 or 75 or 80% reduction in heart failure hospitalizations. And it turns out that those numbers are consistent with what was seen in the REDS HF trial as well. So we've got both a clinical study and sort of multiple real-world use case scenarios here that are all demonstrating a marked improvement in heart failure hospitalizations. And I do want to stress for the audience, REDS technology is available to you today. So if you're not currently using it, and you're interested in it, you have an opportunity to acquire this technology and use it today. So with that, I know we're running short on time, but let's take some questions.